Good morning, everyone. Thank you so much for inviting me to be here today. So I'm going to take some time today and talk to you about sickle cell disease, both as a concept of a health equity issue or health disparity, and then also what we at CDC are doing with our partners to try and help overcome some of these issues and shed some light on what's going on. So first of all, I want to take you back to kind of, not that this is when the conversation started, but when it really became understood, I think, by a larger part of the population. So back in 2007, the American Society for Pediatric Hematology and Oncology hosted a sickle cell disease summit. And the goal of that summit was really to kind of provide marching orders for a lot of groups working in this area as they moved forward over the coming years. And a big portion of that conversation was centered on the fact that we need to recognize sickle cell disease as an issue of healthcare disparity. It's not one of those issues that affects a huge number of people. It's not something that is necessarily on people's mind when they think health disparity. But if you study it and you look at it, you start to realize it might be one of the biggest examples of health disparity that you could possibly imagine. And so moving on from that sickle cell disease summit, groups started really looking into kind of how does sickle cell disease compare to other areas of care, other areas of research, other areas in the medical world. And so those of you who are in the sickle cell world, I'm sure have seen this information time and time again. Those of you who aren't, I think it's really important to understand. So this is a comparison of research funding, and it's looking at the funding that is available for cystic fibrosis compared to sickle cell disease. And what you can see and what I've highlighted down in the red box, which I think is really the take-home message, is if you look at the amount of money spent per patient with sickle cell disease, it's a little over $1,100. If you look at the amount of money spent for cystic fibrosis, another chronic condition that spans the lifespan, it's over $9,000 per person. And so you really start to see here that, that there's some inequity going on. Another area that highlights, I think, where there's a big issue of disparity is when we look at 30-day readmissions. So we all know this is a big issue in healthcare policy right now, trying to reduce these 30-day readmissions. And although sickle cell disease doesn't have the numbers of patients and the numbers of hospitalizations, if you look at the rate of 30-day readmissions and you look across all disease categories and all diagnoses, it's sickle cell anemia that's the number one. Another area that we can see these health disparities is when we look at mortality rates. And so this is some work we published last year now, looking at the mortality rates for sickle cell disease, and we compared these two mortality rates both for the African American population and for the just general US population. And so to orient you to this slide, if you look, the darkest black bars on the left are the mortality rates for people living with sickle cell disease. Moving one over to the right, the lightest bars are for the African American population, and then furthest on the right, the medium shade is the overall population. And so what you see is really once you hit those kind of mid-teenage years and moving all the way up until very late in life, sickle cell disease mortality rate is much, much, much higher than these other two populations that it's being compared to. So again, another issue of health disparity. So there are countless other examples. I think if you talk to clinicians and physicians who take care of patients, they can tell you anecdote after anecdote of things they know to be true in their practice and in their experience. But there are a few papers that have been published looking at this issue, again, to show other examples of highlighting this as an issue of health disparity. So we know that in just kind of looking across the sickle cell community, 50% of the caregivers report a very low household income every year. We know that about 50 to 70% of these patients are Medicaid beneficiaries, and that number differs by state and what the Medicaid policies are in each state. We know that for similar surgical procedures, if you compare sickle cell disease to other conditions, patients have a younger age at the time of many of those surgeries. They have a higher risk of complications. They have longer lengths of stay in the hospital recuperating from those surgeries, and they have higher costs for those surgeries. We know that there are discrepancies in monitoring transfusion outcomes, and this is a big issue because transfusion is a large part of care for people with sickle cell disease. And when you compare what happens to those patients with sickle cell receiving transfusions and the follow-up care they receive compared to other chronic conditions that also rely on transfusions, there are big disparities. And finally, we know that many patients with sickle cell disease, for one reason or another, have to rely on emergency departments for much of their care. And when we look at the care that they're receiving in the emergency department, we see that compared to other conditions, they're experiencing longer times until they get their first medications, and they're also experiencing longer times until they actually see a healthcare provider. And so why is there still uncertainty? Why is it that we have these conversations about health disparities and health equity, and sickle cell disease is really never a part of those conversations? We know that there are reports written by CDC, there are reports written by Congress, there are reports written by other federal agencies that list and compile these huge amounts of data and a lot of numbers about all different kinds of health disparities. And if we're lucky, sickle cell disease gets mentioned in one sentence in the very back of the report. And so why is it that this is just really not coming into these conversations? So I think there's the very obvious elephant in the room. This is an issue of race, and a lot of people are just not willing to take on that issue and really kind of get down into it to the degree that it needs to be talked about. I think there are there's much literature showing that there are a lot of social construct issues that go into these disparities. If you look at many other issues of health disparity, there are a lot of clinical measures. There are a lot of coordinated processes for physicians to follow or for healthcare systems to follow to improve those disparities. Those measures don't exist in sickle cell disease. So there's really no benchmark for clinicians and for healthcare systems to try and achieve to improve the care for this patient population. And finally, a lot of what kind of underlies all of this, and I think Dr. Puckring gave such a great introduction to this, is we are really lacking data when it comes to sickle cell disease. So I was looking on the agenda. I know yesterday there was a huge topic of conversation about cancer and about the cancer registries that exist. Going back to cystic fibrosis, there's a large patient registry for cystic fibrosis. For many of those diseases where we know a lot, where there has been a lot of headway made, oftentimes that's because a huge data registry exists. And so researchers can go in and really understand what's going on, really understand the outcomes, really understand how interventions change those patterns of care. But that doesn't exist for sickle cell disease. And so one thing we need is really to understand this condition from a national perspective, not looking at what's happening in a single institution, not looking what's happening in a small cluster of emergency departments, but really what's going on the national level. And so one way we're trying to kind of get at this issue at CDC, we have partnered with several of the folks who are here in the room who are providing funding for this through our CDC Foundation. And we're working currently with 2 states, both Georgia and California, on a project that's collecting longitudinal healthcare utilization information in our sickle cell data collection project. So here's our new logo at the top that we're so excited we get to start using. And these are really the outcomes and the goals of this project. So we're trying to collect and synthesize, and I think synthesize is a big important issue here. This isn't just disparate data. This is information that really is trying to tell a story. And also to disseminate this data. So we're not just trying to collect it and share it with the experts and share it with scientists. We're trying to just disseminate this information in ways that can really be used by policymakers, by patients, by families, by rules and regulation makers. And so we're trying, first of all, this is very basic, to establish a health profile of the sickle cell disease population. Who are they? Where do they live? Where do they receive their care? And what does that care look like over time? And then we're trying to track the changes in their sickle cell disease outcomes over time. So are there new resources that become available? Are there new clinics opening? Are there new pharmaceuticals coming to market that can actually make a change in those healthcare outcomes? Third, and this is really important, we want to ensure that there's credible, scientifically sound information that can help inform these standards of care. So I think one of the biggest disservices that could happen to this community is if these quality measures were implemented, if they were designed, and if they weren't based on real data. And so really in the long run, they weren't doing any benefit to this community. And so we're really trying to help provide the data that's needed to make sure that these new measures that are formed are scientifically sound. And then finally, we're trying to inform policy and healthcare practices. I think those of us in the sickle cell community recognize that there are some policy changes that could be made that could greatly impact this community. But again, who's going to make those policy changes if the data isn't there to support the change? And so finally, our overall goal is really to improve the quality of life, the life expectancy, and the overall health among those living with sickle cell disease. And so it's a pretty complex project. We've been working on the foundation for this for several years. We're now at the point where we really have quite a large data set to work with. But you can see here in all of the different colors, these are all of the different data sources that we're using. So we're combining data from newborn screening, from state Medicaid, from hospital discharge, from emergency department, as well as some of the larger clinical centers in the states that we're working with, and putting that data all together. And I say that we're aggregating it because we're putting it into one large data system, but it's not aggregated data. It's actually individual level identifiable data. And so what this means is that for each individual living in these two states with sickle cell disease, we can actually see on a day-to-day basis exactly what happens when those people touch the healthcare system. So for those patients, especially those that are available in the Medicaid files, we can see when they go to the doctor, we can see when they get a prescription, we can see when they go to the emergency department, when they go to the hospital, how long they're in the hospital, how many times they go to the hospital over a certain period of time. It's a very rich data source, and the other important thing is we have a lot of confidence that the patients we're talking about in this data system, which are included based on an algorithm that we've been working on. It's very simple, but it's an algorithm we've been working on. We have a lot of confidence that these are true patients. So we're not, again, what has happened in the past, and just because it's the only data that was available, is by relying solely on ICD codes, we're afraid that maybe people weren't studying a patient population that actually had sickle cell disease. They were studying a patient population that had a code for sickle cell disease at some point in their hospital history or their medical history, but those people may not have necessarily had disease. And so by forming this data system, we have a lot of confidence that the research that can be done and the study questions that can be answered are on a patient population that truly has the disease. And so what have we accomplished so far? Quite honestly, I think it's a lot. I think this is really exciting what we've been able to do. So between the two states, I should say, we have about 10 to 12,000 sickle cell disease patients in these two states. And if we think there's about 100,000 in the entire US, even though we're only working with two states, we have almost 10 to 12% of the population. So it's a good number. And obviously we have two states that vary in many ways. They vary geographically, they vary politically, they vary in terms of what healthcare is available in these. So it's really been great so far to work with these. So some ideas of the accomplishments, we published a paper, again, the paper I showed you earlier about mortality rates. And so that was important because we were able to show mortality rates, and that's something that people are very interested in. But what was actually more important from a data point of view is we were able to show that much of the research that had been done previously looking at sickle cell disease mortality and relying on death records to identify those patients was actually missing about 40% of the sickle cell disease population, because about 40% of the population, when they die, sickle cell disease never shows up on their death record. And so if you're relying on those death records to do a study, but you're missing 40% of the population, you're missing quite a bit of what's going on. And so again, that's kind of the beauty of this data collection system, is we know who those patients are, and then we go look for their information. Moving over, we also just published a paper looking at emergency department utilization for the patients in California. It was kind of a foundational paper. I don't think it showed anything that was completely surprising, but it laid the groundwork for a lot of future research we're going to be doing. So drilling down on those patients who have times when they have really high periods of utilization, what is it that triggers that high utilization? And then what is it that helps resolve those periods? Because someone, in general, most people are not high utilizers of the healthcare system throughout their entire life. They're it for periods of time, and then that resolves, and then maybe periods of time later. Further on the right, talking again about the dissemination of this information, we're producing fact sheets, we're producing a lot of social media information. The far right is a fact sheet that came out, and it's trying to dispel 5 myths about sickle cell disease. And so information that's readily available to the general public, to the sickle cell community, to healthcare providers, that really helps try and to underscore knowledge that needs to be known about sickle cell. In the middle of the page, we have a quarterly webinar series that's available to anyone. We try and show information about a large variety of topics. So we have healthcare providers, we have patients, we have patient advocacy organizations. Really try and give a broad overview of what's going on in the world of sickle cell disease. And then at the bottom, and I'm sure you will hear more information about this later based on who's speaking after me, one thing that we're really proud of is we were able to help a group in Los Angeles County identify the gap in care for adults living in that county with sickle cell disease and help to provide some of the data that was foundational in getting an adult sickle cell clinic opened in that county. So that's really what we're trying to do with this data, really trying to help highlight where there are gaps in care, where there is a need, and provide sound information that then can be built on to improve the lives. And so what are our next steps? We want to continue disseminating our findings. We do this through peer-reviewed publications, scientific presentations, social media, policy briefs. Just to give you an idea, these are some of the topics that we currently have in the works. We're looking at maternal mortality for women living with sickle cell disease. Again, looking at high rates of utilization. The mortality paper we wrote about the rates of mortality, we're now doing a deeper dive and looking at what the causes are. What are people dying of when they're in their 20s and 30s? What are they dying of in their 40s and 50s? And then when they live beyond those years. We're developing some videos about personal stories. The current one is a young man living in California and talking about his pathway transitioning from pediatric care to adult care as an individual living with sickle cell disease. And then really what we would like to do is to include additional states. So it's great that we're working with California and Georgia and we're getting a lot of information, but this is obviously quite different from what's going on in other states throughout the US. So we really would like to develop a plan to be able to train and teach these states how to do this work and then implement this large-scale surveillance data system on their own. We've learned a lot in the last years that we've been doing this, and there's no purpose and there's no point in states who want to do this starting from ground zero. We want to be able to teach others how to do this. And finally, what we'd like to do is secure additional sustained support and funding. So as I mentioned before, there are several groups, several companies in the room that are providing the funding for this work. That's quite different from a lot of the work that CDC does that comes from congressional funding. Unfortunately, at CDC, we do not receive any congressional funding to work on sickle cell disease, and so that's why we have to rely on the generosity of our partners. But we really would like to use this information to show just how important this work is and to show just how many changes this work can proceed so that we are able to receive funding for this. Thank you very much.